very close to what we're doing is exactly what we're doing, which is to talk about consumer engagement and the strategies that the transformation partnerships can consider undertaking. And that webinar is on, I think, the 10th of September.
It's the 10th, so the day after we present to the commission. So I think it's a really exciting opportunity.
Right.
First time to put the, get some of this out there and up for discussion.
Right, and other topics have included technology and data, governance structures, and I know that consumer engagement and certainly in governance was a topic or a theme that was also presented in terms of the governance. So it needs to be, as we all know and believe why we're here, a thread through all of the work for those partnerships to maximize their success. So. In terms of the next phase, there's an RFP that will be.
Yeah. So as you know, what is being done right now is the planning phase for these 8 regional planning grantees. In June, the Commission approved, as part of their update factor, some additional infrastructure support that would apply to all hospitals. So that means in fiscal 16, there's 0.4 available in rates. That's somewhere in the neighborhood of, I guess, $80–90 million included in rates for the purpose of infrastructure to try to support, better care coordination for patients and moving the dial and all the things that we need to move the dial on under the new all-payer model. But they also provided 0.25, about $40 million in rates for the purpose of competitive grants for implementation. There was a webinar of the, wasn't just the regional planning grantees, but they had a broad webinar for all hospitals to go over a draft RFP, and we had a Q&A session, or we had some questions and answers period, which I'm putting together now, and we'll have on our website about what the Q&A for that is. The applications are due on December 1st for this. So hospitals will be working with partners, not just the planning grantees, but all, any hospital is eligible for this. And Donna has made it very clear that this is not something where there's a plan out there in place and that something that's going to happen a year from now. This has to be shovel-ready, exemplary programs that can move the dial immediately. We may not have any of those available in the state at this time. And if that's the case, once the review committee looks at all the applications, we may say, the state's not ready. Or maybe there are just a couple hospitals that are at that place where they can, get moving quickly, or take what they're doing now to a different level that's going to really have a good impact for patients. Keep in mind that we've been, there's been almost $160 million in infrastructure funding provided to hospitals. They should be at a place at this point where they can actually make a difference. We'll see once we get the applications in. So there's this is another opportunity for patient advocates and others to be part of this process with individual hospitals, and I would encourage you to be part of that process. I'm sure Susan's been already part of that, and probably Gary as well. So we will have up shortly on our website the Q&A about the RFP. So look for that, and then we'll also have the final draft of the RFP soon. We have a meeting today to try to finalize that. So I would hope next week we would have all that available for you.
And Steve, what's the start date for those projects?
Yeah, so a good question. Yeah, sorry. We expect to approve those in January. The period, I should add that this is a permanent adjustment to rates. That means if a hospital gets, I don't know, 0.3, additional in their rates for this, it stays in their rates. Unlike the planning grants where one-time funding mean they went in for 1 year and then they come out in the next year. So that's why this is fairly significant, because it stays in rates and gets updated over the course of the year. The period for which it will be calendar year 16, calendar year 16, yes. So starting January, it will go into rates in January, February, whenever we get this process done. And the intent is to expend whatever dollars through that first year. But then in future years, the ROI that's provided is designed to support the program going on, plus the money that's already in rates. But that's very important. ROI is the way that we're supposed to support these types of programs. You can't use one-time money to support an ongoing program. There's a very important provision in here that you might be interested in. Our commissioners told us very clearly that while we want to see an ROI on the hospital piece, the hospitals are investing this money into this, and they'll have a budget to share with the partners involved in this process. But it's also important that any savings be shared with the payers. When I say payers, that means people who are paying the bill, and that they are patients from, out of their pocket costs. These are, it's Medicaid, it's Medicare, it's private insurers as well. So we've asked them to report to us as part of this on how they intend to reduce the cost for payors in this process. So that's very important as well.
You said two things that
Gary?
Sorry, you had mentioned two things that are hard for me to understand how they relate. One was that it was a permanent adjustment to rates, and then that it had to have an ROI, and the ROI was the ongoing funding for it. But how does I think of a permanent adjustment as it's there and it's there next year and it's there.
Yeah, it is. It's there every year, and it's not new money. It's the same money. Obviously, stays into rates and it's updated. So those types of things can be used for what is provided in your budget. You might need additional staffing. You might need some contracts or whatever it is. You might be providing dollars to some partners for behavioral health or whatever it may be to ensure that patients are receiving. But from that, from that investment, we expect an ROI. And when I say ROI, from the hospital standpoint, what that means is that under a global budget, as you reduce your utilization, as this program, whatever this project is, becomes successful, you're going to reduce your utilization. You get to increase your rates, thereby accruing additional profits over and above what's in the base rate. So that would be an ROI. And those dollars can be invested in, even further to further make this program successful or expand it into the future.
Thank you.
So that's the ROI, but we don't want it just to go, that ROI to be generated by the hospitals, to be shared with all the partners, but also we want to see a reduction to payers, which could be an agreement where over a period of time that they adjust their global budgets or something like that. That would be across the board, all payer way that they could give money back to payers, and that we're actually bringing down their rates or their global budget. There are other ways they can do that by reducing uncompensated care, which will reduce the cost to all payers in the system. So I hope I didn't confuse everybody by that, going through a rate discussion here.
Steve, so the recommendations from this task force are,
You could turn that around fairly quickly because we'd like to get this out to the public, and the potential, applicants as soon as we can.
we will.
Anthony, was that already distributed to us?
No.
I was going to say, because I missed it.
No.
It was.
It was
It was at the
distributed to
webinar.
public.
Yeah, it was available to the public on the webinar on, I don't know, I can't remember when it was, early August. Tuesday would be fine. Yeah.
Wow. Right. Okay, so I'll get it out to you on the day, and if you have any comments, get them back. We can also talk about it.
I have a quick question. What's it called? What's this RFP's name?
It's called the.
You would have.
We have so many different. Yeah, we have so many different titles. And I should say there are a lot of things going on between here and December 1st. We have the global budget reports. Those are how hospitals invested their prior infrastructure dollars. Those global budget reports are due, I think, the end of September. We've asked hospitals, all hospitals, to report to us on a strategic transformational plan. Yeah, STP. Strategic transformational plan on December 1st, which is, what do you see overall? What is your vision, mission? What do you see for transformation of the healthcare system going forward? So when we get these applications in, we'll be able to see, all right, how well did you invest your dollars that you've already had? And then what do you think, what's your bigger picture going forward? And then we'll get some applications that are an initiative, and we want to make sure that initiative fits within their strategic plan that moves forward.
And those submissions will be transparent, or will they be?
To be, yes.
Yeah. So that's something that, I would think people in the room would be interested in seeing the evolution of those and the particulars.
And
Yeah,
Donna, talk about those on.
What's that?
If Donna could talk about those on the 25th of September at the symposium.
Oh, okay.
Can you? Thank you.
Yeah.
Before I forget.
And then I think Kim asked what the RFP was called, but we're still pondering that.
I've been working
Anybody
on
have
it.
their phone?
What's it listed under when you try and look it up on the web?
Yeah, so you'll go.
I'll send. I'm working on it right now.
Okay.
I'll get it after. Okay.
If there's a name, I'll tell you.
Yes. Thank you.
It's something transformational implementation plan, something like that. Implementation program.
Tip.
Program.
That's good. Anything else on that? Okay.
So you had asked about the commission meeting?
Well, yeah, before we get into the task force and subgroup updates, I thought maybe Hillary's on the line and Diane is in the room, but for those who aren't part of the subgroup or didn't hear this, maybe a report out on the HSCRC commission meeting and their receptivity to our presentation. Diane, do you want to start and Hillary can?
Sure. I think Hillary, of course, did a perfect job of representing the group and also what the content and the thrust of the final report are going to be. She went through the sort of recommendation topical areas, and there was a really good discussion among the commissioners. In particular, I think John Colmers, who's the chair, of course, was very interested in what do we as a commission, what can we do? And we're seeing that in the report. Like how do we involve consumers at a, I think he was implying, at this broader statewide level. And then another commissioner asked a question about do we address the issues of end-of-life care and the appropriate issues that need to be fleshed out with patients and their families that is lacking in the system right now. So I think it seems that that is an area where you have to be careful, but it seems like the time is becoming quite right for that discussion in a very productive way. And so, in particular, Lenny pointed out with the proposal for funding of physician time with patients and families to discuss end-of-life issues. There's a real recognition that that's something that's important and has so much impact on so many levels. So there was a request for that. And then there was also, I think, Dr. Jenks, who was a former CMS person. He used to run the quality programs for the Nation for Medicare. He asked about, I think, return on, like, what is the return or impact of consumer engagement, and how you sort of justify engaging everyone versus the people at the top of the pyramid who need the most. And then I think Hillary did a great job of describing, well, you don't want to get these people to the top, so you get to them earlier. And that, you know, the evidence base is emerging. It's not something that is a clear science, but certainly, as we heard, some of us heard from Linda Aldori about health literacy, and the least literate people do cause the most cost in the system, and so literacy at an earlier, earlier in the trajectory is important. So I think those are the things that I recall after Hillary's presentation in terms of the discussion. So I found that really good, because the commissioners were really listening and are very they're having anticipation about what this report will include, and I think we can be clear and bold in the report is what I think.
Yeah, I think, you know, the commissioners are engaged, so that'll help with the consumer engagement piece of it. Hillary, I hear you weighing in.
I was just going to add that I think the questions taken in whole really give us some advice on how to structure the final report. So, for example, if you consider the question about the discussion around end-of-life care, as well as the question about, well, the rationale for engaging people before they become very, very sick, it's really the same rationale behind that. So that line of questioning sort of points to how much we need to emphasize the trajectory of engagement in terms of that moving people from that point of zero awareness to behavior change, because that really is the foundational principle of what we're trying to do here, and it applies to so many different subtopics within this broader discussion.
That's great, and in my own review of the report, which we'll get to, I think that section definitely needs to be higher up in the process. Anything further on the commission meeting? Okay, so the Consumer Outreach Task Force, Suzanne Schlottman, who has joined us, is in the room.
Yeah, hi. I don't have too much to report. We are finalizing our report and wanted to thank the subgroup, especially Gary and Susan, for their wonderful feedback on that. We were hoping to finish it by the end of July, but there were a few last pieces we wanted to tie up, and then vacations kicked that back. So we're hoping to have that finished very soon, and we'll be sharing that with the group when it's available as soon as possible. Great.
Thank you. Tiffany, you want to report on the joint subgroup?
So I think that Suzanne did our update, because the only thing that the subgroup has done has reviewed the report and provided feedback.
Okay, thank you. And so our task force's subgroup has been working night and day, and particular thanks to Hillary for pulling together the communication strategy document, which I think those on the subgroup know it by heart. And, you know, it's sort of a mantra now. So particularly for those who are not on that subgroup, I think we want to get, you know, any final thoughts, basically approve that today, because that is the bulk of the report. So I don't know if, in particular, Kim and Linda and Barbara on the line have any thoughts, or if any members of the subgroup want to comment. We're not taking major changes today. I just want to make that perfectly clear. No.
I think with the charge being to contribute to the success of the waiver, at least part of the charge being to do that, and the questions on return on investment, should our vision have anything in it that relates to cost effectiveness, affordableness, or I'm just thinking when somebody reads it and tries to tie it back, is it important for us to have that in that vision?
So we had a discussion, I'll weigh in first since you directed it to me. We had a discussion about what the vision versus the mission is. And if the big mission beyond the new all-payer model, which I think is what we're addressing here with the fully integrated healthcare system, which speaks to the new all-payer model in part, but the biggest vision is Marylanders with optimal health outcomes. So that then the mission becomes, how do you make that happen within the new all-payer model? And I think we're getting at that reduced cost with that fourth bullet.
That's true. That's a good response. That's a good way to tie it back together.
Hallelujah.
I
I did something right. That's good.
Again by itself,
Any other comments, Kim?
Well, I got a lot of paper in front of me, so I want to make sure I'm targeting exactly what you're talking about.
So the document that's big, bold, new all-payer model, consumer engagement communication strategy.
No. Never mind.
Okay.
Sorry.
We apologize for the many pages of paper.
Can I, Jenny, did you want to cover the measures which are listed in both places now, or do you want to do that with the draft report?
I think that would be better to do with the draft report.
Okay, that's fine. Just wasn't sure which order you wanted to.
Okay.
Go.
So let me ask if we have consensus on the strategy document.
I have no issues with the strategy document, and I brought this up.
Karen, this is Karen
Ann, sorry, and maybe I'm being pedantic and I can let it go. But in the, and it may be just a space issue, but throughout the document in the pyramid, it describes people who use the hospital services, the general public, and then it calls people high utilizers, which is kind of demonizing in some way. It's sort of the high utilizers then makes them bad guys in a way. And they are the people who are the high utilizers of services, which is way too many words to fit in the top of the triangle. But if there's some way in the rest of the document, or it's some way we could sort of be sensitive to that, because I think it does label people in a way that is not going to be helpful for consumer engagement, because these are people we really want to engage, and people who are high utilizers aren't necessarily that by choice, or that's their only choice. And so anyway, that's just, I don't know how to articulate it on the top of the triangle, but I just want it somewhere in the document.
Right, and it is, so then if you go to the next page, there's a bullet that says high utilizers, and then the next page. So I agree that we should consider a way to message that a little bit differently.
Would frequent users work?
I mean, user itself has a connotation of drugs,
but frequent is better than high in the sense of that is what we're talking about, are people who are frequently and not necessarily appropriately using those services, but that.
If you call it high-use patients as opposed to high users, does that help? Because it is that when you start targeting what efforts you're going to have focusing them on each area, it is the concept of the high use that is important.
I mean, one of the principles is for it to be person-centered. So is it possible to say, you know, you have people who use hospital services and people who use hospital services more than 3 times a year? And that would fit space-wise, right? And that keeps the person at the center.
This is Linda. That would work maybe as a original definition in the beginning, but to use that language throughout the report I think would become quite cumbersome. And I also wonder if there's a debate on how many times is considered a frequent user or high usability.
Well, that actually brings up the point which is in here that says 3, right. Which is a discussion point still among everyone, figuring out who are the high risk.
We've used in some documents high needs patients, and I don't know if that helps at all.
I like that. I think I agree with your point, and I think still kind of categorizing people gets back to your same original point. We're still, if we call them those type of, maybe it's just people that are high utilizers of healthcare versus people that use healthcare, because then you're not calling them it, or because I think all the other things, even if we changed to frequent utilizers versus high utilizers, we're still saying the same thing.
It is the people word because the rest of it has it. It's the dilemma of the triangle. I get it. I mean, it's pragmatics. And so, and maybe just by virtue, I like it sort of somewhere in the document sort of defining who that the high utilizers are, people who frequently use the services, and then by virtue of convenience, using high utilizer in the pyramid.
So in the blue box that defines the primary on page 6, if it was high needs patients, and then no.
Well, the patients is in the next box down. It's people, so I would be consistent one or the other, and I prefer people. But
and to the point of consistency, I think we should pick a term and use it consistently throughout the document. Otherwise, it could get confusing as to exactly what you're referring to later on.
Well, the difference is the blue box are actually people who have gone to the hospital 3 or more times, so they are patients in essence. The middle box, well, they're patients as well since they've used hospital services. When you get down in the other box, they are people, So I don't,
More potential patients.
I totally can live with if in the blue box in the narrative where it says primary and it says high utilizers yet again, if we make that people who are high utilizers or frequent utilizers, and then for convenience leave high utilizers in the triangle, I could live with that.
Well, if it's just adding people who are to the triangle, that might be.
Which would be possible.
High utilizers, people hospital visits more than 3 times a year.
Okay.
The only other space issue I would say is usually when we use this triangle, the top is very small, is a small group of people who have high costs. So it appears here that it's a lot of people who fit that category where, and I know it's just a space issue.
Yeah, you can take out like all payers, but emphasis on Medicare. That's like a footnote issue.
You could put that next to
it. And you could put and caregivers. You could push that way up. All those words don't need to be in there. So.
And I apologize because I don't know if everyone has seen the slide deck that was presented, but I actually think as we're having this discussion, the visual that's in the slide is better than this funnel version, and that might give us a little bit more space to add some of this explanatory language.
Perfect. Yeah, which is I think what Gary proposed, and so folks may have seen that but you should also have seen the slide deck earlier on.
And just to put it in perspective, when we did the 3+, it was about 40,000 people that we're talking about. The middle was somewhere in the neighborhood of 200,000, 250,000 people.
So it is proportionate.
Yeah.
That would be a good thing to have just for reference somewhere. And the bottom is
we could put a.
Could we just add a legend?
The population of the state is 6
million.
Could we just add a legend out to the side that kind of
Gives you some frame of reference
Yeah.
in terms of numbers.
Yeah, and then
Yeah, and we can put that in the report.
And just
We'll put that in the report as well. Pull that out.
And we do have some slides on some of our things that have that, so
perfect.
you can find that.
Lenny?
Yes.
I did find two notes that I wanted to make on, and this is under principles, and I'm not wedded to adding these or not, but on principle number 2, person-centered, from the perspective where I come from, a lot of person-centeredness means personal preferences. So I didn't know if we wanted to add something having to do, it's centered on people and communities, but also personal preferences. And then the other one was under number 5, diversity. The engagement process values and supports the diversity of people, and I wondered if we could add cultures and communities.
I personally like both of those.
Me too.
Okay, approved. Thank you. And personal preferences. Yeah, that's excellent. Okay, anything else from brilliant minds? Okay, so we're going to approve this and move forward with it as the basis for the report. We're going to take Gary's. So we're going to take the one from the slide deck. So can we change
Just
it from
replace that graphic
Meaning slide deck that was presented
at the commission meeting.
Okay. Which said,
It probably says the same thing.
sorry, it says,
I got my glasses.
I need new glasses.
It does say analyzers. So we can adjust it.
What did you say? Whatever you said, I liked it, and now I don't remember what you said.
People who do hospital services.
Yeah, that's not possible in that triangle. Let's figure that out later.
Outside the triangle.
With the legend, with the numbers.
We'll figure it out.
I need people. High needs doesn't necessarily mean that they're using. They have high needs, but it doesn't necessarily mean they're in the hospital. Right. Mm-hmm. Right. Yeah.
We'll work on it. It will go out. It'll be in the draft report that goes out. So if there are any other fine tuning of it, we'll have a chance to comment on it. Does that work for everybody? Okay. So we'll now turn to the final report. And like you all, we didn't, have much time to comment and so forth. And so I'm sure others have started to do what I did, which is to move things around. And I did feel as though the opening, which Tiffany did a terrific job on, but I worried a little bit that it wasn't enough through the consumer lens, and that's really where we're coming from. So I think we're not going to wordsmith that today, but we definitely want your feedback. And so let's come back to that as far as the timing of that is concerned. And we want that today, obviously, we want comments too. And I think our highest priority for today is to look at the performance measures and the recommendations. But let me ask, are there any initial thoughts on the structure of the report from your quick review?
So I had indicated, I guess earlier in the week, I had asked people to set aside time on Thursday afternoon, and I know that at least one person did, Karen Ann. So Karen Ann did give me some feedback. So did you want to share your thoughts, Karen? Oh, well, whatever feedback you gave me this morning. I just didn't know if you wanted to.
Put your mic on if you're going to talk.
No, I mean, I don't have any major substantive changes. And Lenny just said we're not going to focus first page. I thought, first of all, I wanted to compliment you. I thought you did a wonderful job. I think it really read linearly, smoothly, flowed for me. I do think that in the paragraph, the third paragraph, where we talk about Maryland, Chris Foster's promise of eventual IT infrastructure, where institutions can track patients. I found, for some reason, I reacted because that's not about consumer engagement. That's about hospitals, and this is about consumer engagement. So while that is accurate and true, if we want to have some further paragraph about consumer engagement sooner, that we may want to do that. So that was the thought on that.
Good feedback. Just general comment.
And I have offline ones that are really not necessary to, you know.
I mean, Chris does provide a forum for patients. You know, they're working on a consumer portal and things like that. So Chris, I think, can be a huge benefit for patients. Yeah.
I would agree. Yeah. I would agree, and I would include that because it just states here that it's that one piece of Chris. They are doing lots of very cool things.
Yeah, I mean, I would see that as part of the multiple opportunities and initiatives that are going on in Maryland that can be leveraged and become part of the consumer engagement process.
Okay. Do you want me to just do a couple more? I mean, they're
just general comments.
Okay.
If you don't, whatever you have, it's general.
Well, the only other general comment was we talk a lot about in the three things that we want the formal complaints, the patient advisory, and possessing all three. That is there, and maybe this has been discussed and I've just missed it, is the notion that there is an opportunity for nice things that happen, that the compliments section, that people who had good experiences at the hospital or those kinds. So we focus completely on the complaints piece and the response process, and do we want anything in there around that part of it?
So we had defined consumer feedback as concerns, complaints, and commendations. I mean, what there is now is so we'll define that as such in the report, which
that'd be great. When I read the 3 points throughout, it has formal complaint and response process and lost the commendation piece.
Yeah, I mean, the issue is that the formal complaint process is what's in place now, right? So that's what was being addressed, and that's what was being addressed by the survey that Teresa did through MHCC. Which I should say that in the meeting we had yesterday on the webinar, they really, Russ Montgomery at DHMH really picked up on the value of that data in informing the discussion and the need. But I think it's important to point out that this was just the websites,
gotcha.
Right?
Right.
And other things are happening, but how do consumers know about them?
And then the only last comment on page 12, the last one, 6, under the recommendation to establish a standard for institutions to have all three things, references, but it's sort of out of context. So do we want to repeat the three things, or
we're going to come back to the recommendations?
Okay.
And these we're going to develop them and have more explanations. It's just
That's the purpose of the next discussion that we're about to have. Yeah. Were there others besides Karen Ann who took a quick look? Yes, Kim.
I did, and again, this is just adding a word, but I think it's something, a phrase that I think is important that we might want to pull out, and this is on page 4, benefits to healthcare providers and institutions. There's a bullet that says improved relationships with the individuals and communities they serve, and I thought if we put in cooperative partnerships, so it says improved relationships and cooperative partnerships with the individuals and communities they serve. And I was just thinking about that really in terms of the regional transformation partnerships and the need to really say that we want to pull in other community stakeholders. And then the other thing that I was wondering about under the emerging consumer engagement themes, I felt like one of the themes that we came across multiple times had to do with sensitivity to the need for diversity in approach and cultural sensitivity. Mm-hmm. So I know that that's kind of slide in here, but I think it would be nice to break out.
Anybody else? Anybody on the phone at this point?
This is Hillary. I have sort of a clarification question to better understand how these two documents fit together and what the final package will look like. But I also have a couple of just general comments. The only one that I think really needs discussion in the group is the question of in the introduction we use the example of technology to promote consumer engagement, and I wonder if we should use a different type of example, maybe a telehealth example from the national stage or something like that. I fear that using the MHBE example, there are polarized opinions around that, and it could raise issues. So I'm worried that using that as the first example that we give could color the way people read the report.
Yeah, I mean, I will say I deleted that and rewrote that section.
So Diane put that in her outline that we all looked at. Do you want to shed light on why you thought we should include that? And then I can. It's not. It can or cannot be. It doesn't. It's negotiable. There's no. It was among the many ideas. So.
Okay. Yeah, I think it's the MHBE as a vehicle for health literacy and so forth, more than the technology piece at this point that we might be getting at.
Yeah.
Does that make sense?
Yeah.
Yeah.
Yep.
Yes, Kim.
Right. Oh yeah, we already talked about it.
Oh, okay, and number 5 instead of
So, yeah, so to Barbara, if she's listening, so we're going to get to the recommendations in detail. I think that's a large part of what we'll discuss in a moment. Any other general comments? Yes, Gary.
Yeah, structurally, I'm looking at charge 2, and I'm wondering if we're going to contribute to the overall outcome. It does seem to me that one of the things we're trying to do is get patients to take charge of their own health. And we don't cite that here. We talk more about getting them involved with changing the system than we do about changing themselves. And I do think when we tie in ultimate impact on cost, one of the biggest events that we could have is for people to become their own health manager and become responsible for the success of the system. And we kind of, I used that language once in one of the charts that can't lay hands on right now. You're right, which is how do we expect to impact people? Well, we would like people to take charge of their own health, to let their preferences be known, to know more about their disease or their condition, to participate with the various resources appropriately. And it seems to me like that's a pretty central piece to being a success at this in terms of consumer engagement, but I don't see it in the charges the way they're written, and maybe I'm missing them.
Well, the charges are listed as they were published, so these are the charges that were issued by the commission to this group. And the way that I organized toward these
we wrote them.
Oh, we wrote the charges? Oh, okay.
And
they're
and
on the website
HSCRC approved, right?
Yeah. Okay. So, well, this is what's been, commonly referenced as what we're supposed to be doing. And so I listed those as what we were initially engaged to do, and the way that I organized the report just was kind of in chronological order of how we did things. And so at some point we arrived at goals and objectives that do address people being more involved in their care. And so when we're all finished with this editing, we'll have an executive summary, and the goals and objectives will be prominent. So we could talk about order, but I just ordered it like this is what we were asked to do, this is what we did, and this is what we ended up with. And so the goals and objectives appear later in the full report, but in the executive summary, it'll start out by saying these are the goals and objectives. But we can decide if we want to reorganize the report too, if it makes sense.
But I think your point is a good one, that individuals taking empowered or whatever words are right to take charge of their own health if they want to, if that's their preference. So having something in probably charge 2 that adds that component might be a good add.
Yeah, well, let me suggest that under charge 1, your point is very well taken, and it needs to be up front in the report. But the outcome of charge 1 is, in fact, the path to consumer engagement, and that last step of consumer engagement is, in fact, individuals owning their own health, right? So we need to make sure that's clear. I think that's one reason for moving that section up in the report. The second part is really charge 2 is really devoted to that idea that consumers have a role in the policy process through garnering information from them. And I thought it was interesting yesterday in the meeting that Diane and I had about the webinar we're doing on consumer engagement, that Russ Montgomery at DHMH specifically said, wait, where are we going to talk about consumers having a role with the governance and policy? That is really this piece. So that's clearly recognized by the hospitals and others as a need. So I think we don't want to necessarily, I'm going to muddle those two.
So you're arguing that charge 1 is a little bit more appropriate?
Yeah, so if we want to be quite specific there and add that ownership piece as we discuss in the path to consumer engagement. And let me say that the slide, the graphic in here is that you have is not the accurate one. It's not the most up-to-date one. So I think the one you have says the path to health literacy. There is this graphic that will be in there that's similar to that, but it's the path to consumer engagement.
And I think Gary's point's a good one. I mean, I think whether it's charge 1 or 2 and whatever recommendations you're going to make, I think it all gets back to providing consumers with the tools to be able to take ownership of their own health. It's difficult now to navigate the system and understand the system to be able to do that. Some people are good at it, some people are not. But I think everything in here revolves around, why do we want to do all this stuff? Well, we want to give consumers the tools to be able to take ownership and have an impact.
Can I make a comment? I was thinking that if I'm reading this report, I'm not paying so much attention to the charges, because really I'm just looking for what the outcomes are. And on page 11, where we list some of the strategies and tactics, I had made a note under the for consumers section. The first bullet says provide consumers with the information and resources they need to make wise decisions and better manage their care. And I felt like that needed to hit more on what we want for the consumers to be able to do. So the language I would propose tweaking is so that it says provide consumers with the information, tools, and resources they need to fully comprehend their conditions and needs and to make wise decisions and better manage their care. Just a little FYI, I was giving a presentation that talked a little bit about what our task force is doing, and an 84-year-old man came up afterwards and he pulled out his little notebook and he wanted me to share something with you. But first, he also said that every day he writes down something special that happens in his notebook so that he feels good about something every day. And on this particular day, which was August 6th, he said that he saw a nice fish splash in the water outside of his kitchen. But what he wanted me to ask for all of you is that we ask that doctors, when the patients leave with information about what the doctor said, because he says he always forgets and he can't write it down fast enough. And, you know, it was just such a, like, this is so basic, it's unbelievable. But this guy was 84, and he was like, this is all I really need. This is what I want you to tell them.
So, Kim, can I borrow that for the presentation on September 9th?
Sure, as long as you mention the fish. He was
Yeah,
really excited.
I'm going to talk about that fish. Yeah. I wonder.
I have to say that thank you for sharing that. I love it. It made my day also. Now I need a little book to write things down because I don't always do that. But that just really focuses on the fact that it is about people's personal goals and not, you know, and that's what you have to focus on. And that's how you engage people. And that's perfect because now we know that that man likes fish and seeing fish. And so that would be a goal for something that you could tie into his health goals. So I would like, oh, I'm sorry, I was just going to.
He was just really saying, like, I want to understand this too.
Yeah.
The doctor's saying something, but I don't really understand what he's saying.
Very cool. I would, even when we, with the language of provide consumers, it is paternalistic because we are giving to them. And so I don't know whether we want to use the word partnership, partner with, in providing something that we don't really actually focus on the partnership component a whole lot. And while this is about consumer engagement and people owning their health care, I will tell you, because I'm personally involved in the healthcare system, and that there are times where I feel, and I'm pretty savvy, and I feel like things get missed all over the place, and now am I allowing the system the freedom to not have to worry anymore because I'm in charge, and I'm exhausted being in charge. So I do think that there's some notion of this partnership that it's not, what we don't want is the pendulum to fly to the side of, you know, to be clear in our consumer engagement that it is, we want people engaged, we want people to understand their health care, but we wanted a partnership.
Yeah, I think, in fact, on the path to consumer engagement, that healthcare piece, healthcare literacy piece does create that partnership, so make that more explicit. Yeah. And based upon, again, the webinar conversation yesterday and something that was just said earlier, I wonder if the methodology piece of this might sort of migrate more to the back so that we get up front some of the stuff. I mean, the commission needs to know what our methodology was, but you know, can we just put in a short bit about that in the front and then put the content of it later in the report? I felt as though I was slogging through a lot before I actually got. Hillary, yes.
Sorry.
Hillary? Yeah.
If we could go back to the partnership question for just a minute, because I absolutely agree that the partnership piece is essential. At the same time, though, we have been saying that the system has to carry the onus for making this happen. And I worry that if we're not very careful with the language, we could inadvertently create an escape path for the system to say, oh, well, you know, it has to be a partnership, and the, you know, the consumers that I've been working with, you know, for anyone along the provider, just didn't seem that interested in the partnership. So while I absolutely agree that the partnership is essential, I just think that we must be very conscientious about how we present that so that the onus does remain on the system to transform so that those partnerships become possible. Because we do have a prevailing culture where it's sort of, oh, well, the healthcare system is a system and it's this huge complex thing, and, you know, providers are on pedestals and it's difficult to ask those questions. So we need to create an environment to break through that.
It's a very complex relationship because in the end, the patient is the care manager. And if the system puts him in a hospital and provides him with a care plan that will produce a good outcome, the patient can still pick up and leave. And we can't negate that right of the patient to be in charge. But I do think the responsibility that we try and work with is to make sure that the patient who wants to be engaged can be, and that the system the system reinforces that approach. So it's tough getting both those to be on key at the same time.
Any other general comments? This is not your last opportunity. Okay, so I'm going to turn it over to Diane.
Yes, and this is, so I pulled out some things, just the recommendations from the report, and then I also pulled out for the various audience, the strategies from the communication strategy, because I think the issue that Tiffany raised is one also that I'm hoping we can work through and address, which is where are the intersections and what is the communication strategy document doing versus what we want to be in the report. And further, there were some very powerful things that rise to the level of recommendation in the strategy part of the communication report that I think we need to consider as putting them in as subsets of full-on recommendations. So you understand what this is literally cutting and pasting the strategy section of the communications plan with the 6 recommendations that are in the report now. So with that, we can sort of start to look at the current recommendations in the report, and then folks have already commented on these. So I wanted to then move quickly to the strategies for all stakeholders and see which ones of these may either be a subset or a recommendation unto themselves. Because I think we can be, it's confusing. There's a ton of overlap between the communication strategy and the report. So hopefully we can work through it and land on the differentiation between the 2 documents. So the next slide has the strategies for all stakeholders. And I think that many of these could rise to the level of a recommendation. And I should say that the Commission votes on recommendations that are formal, and I don't see these as those kinds of recommendations. They're not a policy that is going to be put in place. They're advisory recommendations, so there's no policy action per se on the side of the Commission, except to work toward putting in place what is recommended, to the extent that the resources are there, and if need be, to prioritize which one should be done first. So as we think about these, if we can go through these strategies for all stakeholders, think about the prioritization of those and about which ones maybe rise to the level of an actual advisory recommendation to the Commission.
Diane, just on the first one, again, develop a statewide public education campaign to promote consumer ownership of their own health and wellness. And the reason why I'd say that, and I know the argument can be made to promote health and wellness in general, but that's kind of not our task, as that's more of a public health task. Our task is to get consumer engagement that will help us with this waiver system. And I think being a little more clear on that would be useful.
Okay. So if I could speak to that, because I was going to suggest that I think what we discussed was that we need the broad statewide public education campaign on health and wellness. And within that construct, there is a very specific HSCRC promoted campaign specific to the new all-payer model, which is what we've addressed in the rest of the document. So, I think we were talking about the big campaign with this one within that is very focused.
Right. So I think it still we can adapt that larger campaign to focus on what are we advising HSCRC to do. So I think this one with Gary's tweaks could be one that is something that.
I mean, you could say within the construct of a statewide public education campaign to promote health and wellness, develop a NAPM-specific campaign.
Mm-hmm.
I apologize because it does seem like I'm looking at each of these independently, and I don't. The comment about understanding how this is all going to fit together, it's hard to look at each piece and not say, well, you know, it should say this because, you know, it's important to say that. Well, it's may not be important within the section that you're looking at, but without the whole document, it's hard to parse sometimes which areas you should tinker with.
Yeah, I think that with the broader context, if we accept that this is being read after we've already clearly laid out the case for consumer engagement and explained that it has to begin, you know, before people are interacting with hospitals, then does that begin to make this more comfortable for you?
I think it's hard without having the whole document to review to see kind of how comfortable you'd be. I've raised, you know, the point, and I'm comfortable with the folks who are spending more time with the document, making sure that the flow gets the right things up front, and we'll have a shot at that too later. So it's not terribly important to address instantly. I just do think that the flow, when you're reading it as somebody who hasn't been involved with all of this, the flow will be important, and keeping the consumer primary in the process, the patient primary in the process is kind of the objective of several of the comments that I've made, because they're going to determine how much use we have in the system and whether this system works well or not. And our ability to add on new services and do things like that will be only possible to the extent that we are more efficient than we are now in using the services that are the baseline. And so to be successful with our charge, it all has to tie back. And maybe I'm confusing things more than I'm helping at this point, so I'll quiet down.
In terms of public education campaign around health and wellness, certainly DHMH does some of that, and I think you probably need, they also have the resources, better resources, you know, to be able to address that. So I think they need to be part of that process. In terms of a all-payer model campaign of some sort, as you know, we've been looking to consumer groups to help us with that. Obviously, we do not. We've received the all-payer model, and you know, hardly any other staff in essence. So we really don't have the staff to be able to have a wing, if you will, for that campaign. But what should happen is we should be working with consumer groups and understanding what it is we should be doing, reaching out to whom, where, and being part of that process. But I think it needs to be sort of stakeholder-led, but with us involved in the process. Other than maybe DHMH on a larger wellness and campaign, I think that that's part of their mission.
Yeah, so I think you know, we try to get at that with the second one, which is the coordination of all of this work. That goes to our what's in the report, that there are these multiple opportunities. They don't stand alone. They're not in silos. We have to integrate them.
That's a good point.
So.
Right, and the next one too, the interagency task force with consumer reps convene, you know, that we facilitate, could be a really beneficial. These other ones underneath are the details of the communications strategy, I think, but the first two or three, and then seem to be, to me, the ones that could be good candidates for putting in the report.
I would agree. If you're going to use the bottom ones, I would just suggest changing the word allow hospitals, social services to encourage hospitals, social service providers, consumers to localize.
Right. I think that is sort of a detail about the strategy is that once it gets implemented in the implementation.
I was thinking about on point number 2. One of the things that I've brought up a couple times, we've discussed a couple times, has to do with the disconnect of different programs that are already, or initiatives that are already underway. So if we use Community First Choice or the Community Options Waiver, where we already have consumer groups that meet, instead of, well, first of all, instead of doing another interagency task force, we could bring this task to the consumer groups that already meet for these other initiatives. And these are also initiatives that they have their own handbooks, you know, so they've got information that's already going out to people that use those programs and also people that are interested in those programs. So we could add to the materials that are already going out. And that, I think, would be wiser in terms of resources. There's also a quote-unquote registry of thousands of people who are waiting to go into these really critical health programs. And they're just kind of waiting. And they are right on the cusp of being hospitalized. So I think that that's an important group that we should try to capture too. That's through Department of Aging. So I thought that Department of Aging should be added.
And I'd add the Department of Disabilities then, Maryland Department, MDOD also.
So, I mean, again, it just shows the value actually of the longer communication strategy document we did, because those entities aren't listed there, I think, in that point made. So we just need to be sure that that's pulled out. I think the thought of the interagency task force was that there are all of these programs working out there, but who's, I mean, I'm sitting in many of those individual meetings, right, and they're completely unaware of what's happening at other places. So somehow pulling that expertise and those ideas into a single vehicle was the thought behind that.
And Kim, I will say that I think that when I read bullet 2 and it's all state agencies, and that bullet 3 of having consumers a part of that in some fashion feels important. I don't know about, I agree with you, creating yet another task force kind of concept, but we're so strongly talking about coordinating among all the state agencies that I think it's really important that the consumer representatives be somewhere.
So that's why it's going to be coordinated under our rubric with the Standing Advisory Committee that HSCRC, we hope, will set up, which, yeah.
So that's the other point, is there's overlap in, I think, with all stakeholders and within the individual stakeholder groups. So as we go through these, there's some repetition, but this is pulled directly from the communication strategy, which is fine to have it like that there. It's just when we get to the recommendation, the advisory recommendations, we want to be as concise and non-repetitive and recognize where there's overlap there. So, so are we thinking the first 3 are with the tweaks that Gary mentioned, and Lenny on the first one might be candidates for the final recommendation? Okay.
Given the flow of the discussion, does it make sense to put number 2 before number 1? Because number 2 recognizes the coordination with the existing mental or public health messages, and then number 1 is deriving from that. How do we impact or fit into that process?
I would say not only that, but that as we look at the others, so for instance, on the next page under the policymakers, where we have the consumer rep on the commission, and the creation of the Standing Advisory Committee, that really those probably should be the lead ones. If John Colmers wants to know what we think they should do, I think those are probably the very first ones, because those also establish a process for continuing the work that's been done to date. So we may, I guess that my thought, Gary, would be maybe look at all of these and then figure out what the priorities are and looking at the sequence. Exactly.
Right.
Yeah.
Because the effectiveness of the report will depend on whether somebody who hasn't been in our discussions can see the flow.
Yeah. I'm giving it to my husband, actually, once it's in its next iteration. He's a great fresh eyes.
Oh, that's good.
Yeah.
So I think the title on the next slide is important too. Foster consumer-centered healthcare system with policies and procedures informed by stakeholders, and that is a sort of an advisory statement. And then these things. The reason I put it in the title was that it was the only A and there was no B, so it was the point of all of these. So I believe that. That statement is a good statement. Steve, what's your reaction? Because you're seeing these for the first time, and I've been in this group about consumer rep on the commission. Let me ask you point blank. Not to put you on the
I didn't have the nerve to do.
It's a small commission. I know the commissioners and chairmen are, it's important that we
right.
have that.
But I didn't know if there's been a historical sort of context of that issue. I've not been part of it.
There hasn't, and what the concern is obviously we're now moving to a total cost of care model, which involves more providers, and consumers are just as important as providers. But so nursing homes are now going to be part of the process, and other providers that we typically haven't had. We've had physicians on always. So there's going to be a demand on the commission for expanded, physicians that represent that. My personal opinion is, I think you can get just as much or more done on a work group that goes to the commission, on the front end, on the ground floor and on the front end and developing. Because as you see, the commissioners typically, accept staff recommendations. Not always, but for the most part, 90-some% of the time with some tweaks. So I really think you can have a huge impact through the process that's taking place now, and even some of the processes you're talking about in this paper, expanding that, having a multi-agency group which has more clout with this. So I think sometimes you can have as much, even more power, if you will, on policy at the commission level here. I don't think you necessarily need somebody on the commission for that.
Can I push? And we're colleagues, right? So if we believe that consumers are our partners and people who get services and need services are sort of the reason for the commission and the reason providers even exist, and if we say that if we notice that they're absent at the commissioner's table, I don't know what kind of statement that makes about the level of importance. And
I think if you ask every commissioner on our commission, they would say that they are absolutely a consumer. One of the great things about the commission.
Good point.
One of the great things about the commission over the years, and those of you who have been around the commission for a long time, and this is what makes the HSCRC different, is that they check their guns at the door. You have the hospital representative voting for cuts in their rates. So they typically, even though that they have a position, outside this room, when they come in, they come in and vote in the best interest of the all-payer model. And I'll tell you, if you asked every one of them, they would say that I am a consumer, and in one way or another, I also represent consumers as a physician, as a quality expert at ARC, or as a hospital representative or otherwise. They always, and I can tell you, and Steve Jenks and others, when we're in, executive session, they are pounding, from the perspective of the consumer and the patient on a lot of this.
So everybody wants to speak, including me. So Karen Ann first.
So I agree we're all consumers, and every one of the commissioners are. I would like to, and I like to think we're colleagues also, even though I'm not in the, I would like to leave the recommendation in for the commission to look at it, because I feel that if we really are talking about consumer engagement and having consumers be at the table, then being at the sub-tables or the tables that present to the table, because and I agree with you, the work happens at the table before it gets there, but if we're saying you don't need to be at that voting table, you don't need to be at the final discussion table, then I think that we're not as powerful as we would be with a consumer. Now that said, it's very tricky because tokenism is not where we want to go. And I have sat with many, many boards with people with disabilities where I believe that that has been the case. So it's very tricky in terms of getting consumers who are powerful speakers. But when I hear Kim tell me about the 84-year-old man who puts it right there, which is what the one thing he needs, I think there's wisdom to having genuine consumers other than the professionals who we also happen to be consumers. So I would like to at least leave it as a recommendation, hearing for it to be looked at.
Gary?
Steve, I'm actively engaged in the same discussion at the hospital board level. And the president of the hospital and the people who are comfortable with the structure the way it is look at this and say, we are all representing the patient. The real tricky part is, who are you primarily representing? When it comes down to it, is the hospital representative, if you come to the question where they think the cut is really going to decimate the hospital versus having some inconvenience to the patient, who are they primarily representing? And the same with the payer reps. And so when I'm talking internally in my own organization, trying to get a person who is principally charged with representing the consumer, it is not somebody from the community that we want to partner with. Those people are there. It is not somebody from the payer community or the business community. It is somebody who is trying to represent just the buyer on the other end, the people who get this product.
Right, and I think that was one of the reasons why they appointed Steve Jenks several years ago, who doesn't have a provider base. And quite frankly, our statute says that we cannot have a majority of our commissioners who are associated directly with a provider, and part of that is for that reason. But also our vice chairman, who's with ARC, who's developing quality measures for the purpose of improving patient care. So I would argue that many of those sentiments are brought forward in what we hear from our commission.
I think.
So this is. Sorry, go ahead.
Go ahead, Hillary.
I'd like to chime in on this with a slightly different take, and that is the perspective of being a role model. If we're recommending that hospitals and community-based providers include specific patient voice in their governance structures, then the commission would need to also demonstrate that as a role model for the other groups where we do want to see more of that consumer voice, and it's direct in the sense of patient family advisory councils at hospitals and with community clinics and so on, but also it's lateral. It would be wonderful to see more consumer representation on other state boards and commissions. So demonstrating that behavior is, I think, very valuable.
Yeah, I should also add that we don't appoint the commission. The governor appoints the commissioners, so we have little say in who actually is. We have some, but it's really up to the governor who serves on the commission.
So, I mean, are the positions, I'm sorry, are the positions defined somewhere in the government, so the governor just chooses the people?
It says that a majority, though, can't be directly related to a provider, so they can't be a hospital.
So that's the only thing defined?
No, it says you have to have, we're 7 commissioners. But I think what Karen Ann was asking, are the slots determined?
Yeah, like if it has to be a doctor, or does it have to be a...
No.
Yeah. So there could ostensibly be a consumer.
Yes, there could be.
So we have to recommend it to the governor, not to the commission. Is that what you're saying? Well,
that would be one place where it would have to go. But I think our commissioners would, are interested in the makeup of it. So, I think it would start with talking to our commissioners about the idea. So maybe you say in here, if you're going to go forth with this recommendation, that suggests that the commission consider, having adequate representation from, consumers or whatever, interests of consumers on them.
I think it's important to have the recommendation that there be one person principally charged with that. And part of it relates, I think it was Suzanne who was talking earlier about, or maybe it was the lady from Consumer Reports who said that consumers are only inclined to get involved when they feel that it's going to impact the outcome, when they feel there's something specific they can do to change the outcome. And I think to have somebody, if we really believe that the consumers are essential to success of this process, having somebody at the pinnacle of the decision-making process is an important piece of being able to say to people, this is your system, this is your health system. You have the ability to impact the system, but mostly, but secondarily, you have the ability to impact your own use of the system, which is cumulatively going to impact its success. And I think you have a harder time if there's not a focus point where you can say, and this guy's at the table when the decisions are made.
I would say that 99% of the consumers, except for those who are leaders like in this room, would never know whether there's a consumer representative on the HSCRC or not, or even what the HSCRC is. But I don't disagree that we do need to have some, that perspective represented on the commission. And I think the groups that you all are, creating and from a staff level bringing recommendations up really provides a lot of ability to make change in that perspective.
So just because we have an hour or so left, I think, and we could spend all day on this single issue, but let me just point out that in September of 2013, at the first commission meeting that I attended on the waiver, when it sort of bubbled up, which is an issue, as Steve just suggested, that making sure that consumers actually know what's going on, that's a large part of this challenge on the governance end of things. But when I and others spoke up and said, I'm looking around the table for the advisory group, which it then was, not the commissioners, and said, I don't see a single consumer rep at this table. And the response was, from Steve Jenks and others, you're absolutely right. And Vinny and I were then asked to join, basically, the Blue Ribbon Committee. So, which I'm very pleased about, don't get me wrong, but to Karen Ann's point, how influential is that in the actual process? That said, a real effort was made by the Commission to get consumer reps on those work groups, which have had a real impact on the design and implementation process. But I think for the purposes of our task force, consumer engagement, we're just putting the recommendations in, but I think that we would, personally, I think we would be doing consumers a disservice if this recommendation wasn't in there. Now, perhaps it's slightly reframed So whether it's promote a position for consumer representative or whatever it is, given the fact that the governor appoints. But I personally think it's extremely important that as the consumer engagement group, we make this statement for the reasons that others have said, and Kim is about to weigh in.
I'm wondering if there's a way to write it so that we can leave open a mechanism for consultation with the consumer. I agree with the importance of a consumer being on the board, but the reality is everybody on that board, if they have an egregious health issue, can get that issue met in a couple of days' time. And for, I think, the consumers that we're talking about, that we are really, really talking about, those folks are waiting months. They have a lot to teach those that are commissioners. But the gap between what the work that needs to be done here and the understanding here, and this isn't to slam people. I just don't think that putting a person whose experience here over here is going to really get to what we're trying to do. I think what we're trying to do is to get this group of commissioners to really consult with consumers. And I almost think of, an example of having the meeting that they can go to maybe a base of people instead of just having one person be a consumer rep. So if we were to explore mechanisms to truly get to what we're looking for.
I think what you're talking about is the construct of the Standing Advisory Committee, which has a liaison from of a commissioner to the SAC on the model of the Maryland Health Benefit Exchange, which that, it's had growing pains and so forth. But that's, I think, much like the MAC. I think that's actually what you're talking about, Kim. And more feasible, I think, for the HSCRC to put in place. At least we're certainly hoping so.
Kim, the structure of the Consumers Union is kind of that in-between player. It's having people who are sophisticated enough to do the analysis and stuff to represent the people who don't know about car safety and translate things back and forth to them. And it's very tricky to figure out how to have influence at the policy setting level with someone who doesn't primarily see it through their own lens, whether it's primary care or hospitals or payers or whatever. And so and we've had this, I've been actively arguing and becoming a pain in the butt on the hospital side to get someone whose principal mission is that. And my recommendation is you really need to have someone who fills the role that the Consumers Union does for consumers in many complex areas about health safety, food safety, whatever. But you need somebody whose allegiance is not questioned, who then works with advisory committees or groups of healthcare people from the community or whatever to pick out which things they think are in the consumer's best interest. So that's kind of, and my discussion is shaped by, of course, the people that I'm having the discussion with, and having them challenge me and say, well, each of the people who are there have been in the hospital at some time or another. Well, already you've got to select a group, and it's which hospital were they in, and how did that hospital present their information? This is a basic challenge.
So having a little less than an hour to go and substantive decisions to be made, I just made a suggestion to Diane that we reverse, perhaps reverse 1 and 2, and then we can wordsmith maybe that first bullet. But are we in agreement that we should keep the concept in there? Okay. And just for Karen Ann, before I forget, if you look at bullet 4 on that policymakers foster, you'll see that we talk about the feedback and the comments, complaints, and commendations. So that is addressed. So Diane, sorry.
Oh no, that's okay. So I think the good news is this is provide incentives to support regular, longitudinal, effective consumer engagement, and I think in the issues of infrastructure and partnerships, that is totally the direction. The train is on the track and is doing that. So we can say continue to provide. I think is a good recommendation here. And then I would skip down to coordinate. These others are sort of, these middle ones are, to me, more communications
Oriented?
Yeah. So they belong squarely in the communication strategy, but not necessarily in the recommendation. So in the last bullet here where it says, a consumer gold star, consider developing a consumer, quote, gold star system. But I see this more in the MHCC realm because they do public reporting and they add various domains and to their hospital guide. So we have to talk with Teresa and Ben, but I do believe this would be a good recommendation for them. Sorry, thank you. Yes. So in coordination with the SAC, develop and promote a consumer gold star system that we consider that for hospitals based on consumer engagement standards. And then to include is too emphatic, so that may include, or that with potential inclusion of, because it's all about the measurement, and the gold star is worth a gold star if the measurement underneath is sound and scientific. So this may be a difficult thing to get to, but it could be developed if smart minds put their attention to it. So, I'll just change that language a little for purposes of this recommendation.
And everybody agrees with those as prime recommendations.
You all, everybody. Karen?
Maybe you said this, Diane, I just didn't get it completely, but so the second one under the gold star is ensuring that patients understand their rights, which is really difficult to measure, ensuring someone understanding. So was that what your kinds of things that
this was really lifted directly from, so exactly. So to me, these are going to be, we have to develop standards for each one of these sub-bullets and a methodology to measure it. So that's why consider consumer engagement standard such as, and then that measure concept such as, or something like that, because we don't, I can't tell you, there are surveys and things that do some of these things, and they're on the measures grid that we're not, possibly not going to get to, but hopefully we will. There may or may not be the right tools to measure these things.
And I think, I mean, that's why we put in coordination with the SAC, because this is a perfect example of why a SAC would be useful. Is that good?
The next one goes to the providers, and I think just the title, incentivize hospitals to support patients and caregivers' ability to manage their own care, including access. This is a lot of overlap with that the other incentive bullet on the previous page, so we could somehow consolidate those is what I was thinking. They're very similar in the language, and I think they're getting at similar concepts, to be honest. But one's under provider and one's under policymaker. And then that bullet, I'm curious about this one. Reward independent and collaborative approaches to support patients who are at risk of becoming high utilizers, such as medication therapy, motivational interviewing, health coaching, peer support. These are the interventions, if you will, that I think a lot of the care coordination work that's already fits under that category of incentives. So, and the word is reward. So it just falls to me. I don't know if we want to be this specific, but being this specific also makes a point that people need certain things and simple things. So it may be a good approach to leave some examples. of what we're talking about in terms of incentives and behaviors and structures that we want to incentivize.
And let me suggest that this goes to the fact that we have a long list of messengers, and this reinforces the idea, I think, that there are multiple opportunities across the board for different messengers to provide different messages in different ways.
Okay, I think putting the words the plethora of messengers or the potential messengers, adding that is a good potential messengers. And then we move on to the next provider page. Encourage and reward emergency department-based patient navigation. It's sort of examples of, it's an ED navigator is an example of the previous bullet. So okay, the transparent cost on procedures. I think that is a I don't know if that is the hospital's job or the state's job. That's bullet number 2. Require hospitals to provide current, consistent, and transparent information on average procedure costs using the data made readily available. So we want hospitals to use the data, and make it available. And that, I don't know that would that be something the commission would require?
Right. I think the idea behind that when we were first putting it in was to say that, you know, we know that this data is available, but the average consumer isn't necessarily going to be going to state websites to look for it, but they will be expecting something or in contact with their health care providers and the organizations where they're getting care around this. So it was to use information available and be a distribution channel of that information.
And I think, Hillary, correct me if I'm wrong, but I think really that goes to the next set of recommendations under consumers and, and providing them with the resources. So the website, and we're saying this information has to be available, whether it's through MHCC site or a new all-payer model site or whatever it is.
No, not quite. We're saying that hospitals should actively give patients this information. If someone is going in for a knee repair, they should be given a range that says, you know, if you look across Maryland, this is the average for a knee repair, and of course, it depends on the individual procedure and whatever complications there may be, but this is to give you a sense of where it's going to be.
Yeah, there's already a provision in either statute or regulations that requires hospitals, upon request, to provide a patient with an estimate before an estimate of what the cost might be. Obviously, you don't know because there could be other complications at the time, but
right.
So there are already some things in statute that that we might be able to use to enforce kind of this thing, or at least notify patients that they have the right to do this.
That was going to be my point, is how do consumers know that they can do it, right?
Right.
And then there's the MHCC work group now that's looking at the top 10, 20 procedures and the costs of them, and bundles. Okay. Oh, I thought you were on that group too.
Hopefully, I just don't know it.
No, you may not be. I may be confused. So there is a group that the MHCC's they are working under a grant to look at publicizing costs in a user-friendly way. So when that in Maryland QMDC, that is the quality thing that MHCC maintains, and I think that's where the data will go on cost. So that's why that's there. So okay, so that and then collaborate with the regional transformation grants. I think that providers already need to, they're doing that. So I don't know that that needs to be a recommendation. And then there's the last two that are the consumer buckets, and then I think the header in the slide is a really a good statement, but how can we fashion this into a recommendation for the commission if we think it's
Diane, can I just make a comment? This is one, I know we don't want to change a bunch of things, but this is the one where I was thinking that we could have it reflect that the consumers comprehend their health profiles, needs, and risks so that they can enhance decision-making and self-care activities.
And would you put that as part of an individual? There's 2 pages of consumers, so I just want to make it. Did you see it?
I think you're speaking to
the next one.
Well, no.
It maybe needed to be added. Kim, you're raising it because you didn't see it in any of the documents, right? You're not adding to a different bullet.
I don't know. There's a lot of bullets, so
yeah,
I mean, I think that it doesn't need to be said if it's in there, but
it's in the communication strategy. So these are straight from the communication strategy. So when we were reviewing that, you gave that feedback on this particular bullet in the communication strategy.
Okay, so I took this from the most current communication strategy,
Right.
which does not reflect Kim's language, right?
Right, because she just added it today. When we were going through the
Earlier,
communication strategy, she added that.
That's right.
So the only thing that,
so I was just clarifying, so that will already be added, and then this will reflect what's in the communication strategy, so it'll get in.
the only question I have is create a comprehensive searchable guide to community-based resources. That would be number 57,000 of that. I have some worry as a recommendation because there are so many resource databases developed in so many areas, and I'm not sure what we're actually saying there for community-based resources.
I think this is too detailed.
I would agree. I think it should be more general in terms of the goals or the outcomes of what we're trying to get at, that consumers have access to, the resources they need, kind of thing, because I'm worried about creating another database.
Right, and then the detail stays in the communications plan, but I think the header, which was the A of the B, if you will, is the goal statement, so the commission would promote or incentivize the provision to consumers information and resources, something like that.
So on page 8 of the strategy document, we have a section, consumer-centered approach to materials development and minimum considerations. So I wonder if we don't want to reference that within the construct of the recommendation in some way.
The minimum consideration.
Yeah.
Okay.
Yeah. With the note about plain language.
Right. Okay. So if we use the header bullet, reference the minimum considerations piece, and as well as plain language.
Well, I just throw that in. I mean, I love it because we're telling them that this report is not written in plain language, and everything they do should be.
All right. Well, there's the what is the term that Hillary used? Let's be a role model.
Right.
Okay. And then I think,
Well, I don't know. It's really difficult to write a report like this. If we're trying to write it at 6th grade level, it's going to be
absolutely.
No, we're not.
Okay. Right. So you're saying plain language. I'm like, I don't know how.
No, we put in the note in the report that said, you know, we recognize that our report is not in plain language, but that in fact the materials you develop
for
is under the
consumers.
materials.
Yeah.
We have considered our audience and their culture and create.
Okay, let's.
One problem I have with this, though, is if you add up just the number of main bullets in it, we're at 37 recommendations. And as an administrator, one of the things that I've been guilty of early in life a lot of times is having people give me a report that I know will include 50 items so that I can pick the 4 that I want to do and say, you know, the report supports these, you know, 6 or 8 of the items that they suggested are in these 4 categories. And I think when we give them so many recommendations without a priority, we leave the field open for somebody else to take all of our discussions and reinterpret it to what they would like to put down.
I think I count maybe a dozen that we pulled out. It wasn't in.
Okay, I was looking at just that major header items on what was here in this discussion item. So.
Okay. Well, the other thing I think too is that we did break it down in the strategy document, and as Diane has done here, into the category of stakeholder policy folks, stakeholders, consumers, and hospitals. So, so they're going to tend to hone in on those that are under their bucket. Now, for HSCRC, they need to own all of them, and I think that's a statement that, again, we need to get in the report.
Karen Ann's comment made me think about when you talked about the developing the databases and the like, about so many things going on. You know, one of the groups that I'm on, and I think Kim, you're part of this too, the Weinberg Caregiver Initiative. And so a lot of the foundations are trying to do the same work, developing a database to provide resources and the like for those that need services or care, particularly, you know, the Medicare population. And so that made me think about when we talked about the interagency, you know, task force or work group, about also including some of the foundations, because there's a large movement right now where ABAG, all of the foundations are getting together to try to develop the same things that we're talking about. And so that may be for a good consideration as well.
So adding them to the, in the bucket, in those. Okay, because they're not there now.
Yeah.
Yeah.
What is the acronym you use?
Well, that's ABAG, but that's just Baltimore. So.
Yeah. So like the Weinberg has a very large senior caregiver initiative, and their approach right now is making Maryland the best place to grow old, and so they're trying to do a statewide approach, and it's just so aligned with the same things that we're talking about now and what's going on in creating databases for resources, and I think there needs to be some cross-pollination.
So what if we said foundations with a healthcare mission? Or I think foundation. Or just foundations?
Yeah, maybe just foundations, because a couple of the other ones are like the Stolman Foundation. A lot we're having the same conversation.
There's also the ADRCs that have a resource database for what it's worth, and so that's why I was worried creating yet another one with the internet that we got.
And we at the last meeting we had at the last meeting we did mention, or someone mentioned in the room, about with the foundations coordinating with some of the agencies that are doing this work that's related to the waiver, because you know we're just kind of operating in silos with all the same goal.
And we really need to move on, because we also have to talk about the budget, if Hillary's going to weigh in on that at all at that point. I was going to say that, in fact, in looking at how this gets paid for, looking at foundations for this project that we're working on, that's part of it too. So they should definitely be on there.
Right. So what I think is, as I peruse the consumer, the rest of the consumer goals at the top in the header. I think I like the language of them create a sense of ownership and involvement, and so I think in the new all-payer model for prime audiences, but I think something like that, HSCRC. I will have to think about what HSCRC could do versus how that fits into the communications plan, and because certainly we could promote and we could provide a couple of that the commission consider things such as, and then list a couple of examples. So if I can work on this in particular and get this turned around into the document as you know, a manageable set of posts, then you guys can prioritize and edit. I think it'll be an easier process. But I think we have really strong recommendations already in the mix of things that we've been working on in the last several months. So I think we're not lacking recommendations. So really the trick is to make the ones that we feel most strongly about, to bring those to the commission as in terms of advising where we stand on these issues. So let me try to do that task, and I will work with Lenny and Tiffany to get that done, and we can move on.
And so do you want to move on and discuss some measures?
Sure.
And in fact,
I think they're, thanks for being the driver on that. Oh, here they are. In the room, we have a hard copy of the measures. Oh, yeah, there they are. At the top, it says consumer. It's a landscape chart that says consumer engagement task force potential performance measures, and the date of update was the 18th of August. And really, what we attempted to do here is pull measures from the universe of measures that we know exist, and match them up, not perfectly, but albeit an attempt to indicate that we are trying to measure parts of each one of whether these goals and objectives are being achieved. So, and also you'll notice some of these measures may be more general, but they're stuck next to a particular goal or objective, and they may apply with, there may be a one-to-many relationship or a many-to-many relationship. So with that caveat, let's just, I think Tiffany had mentioned, let's make sure we cover all the bases, and then if the relationships are many, that's perfectly fine. So the first goal was to establish a consumer-centered health delivery system with an ongoing role for consumers to participate in the design and implementation policies and procedures. So that was seen as a higher, participation of consumers, the higher level goal. And then we've already talked about the Standing Advisory Committee suggestion, and then we just pulled in the language of what the components of the Standing Advisory Committee are for using the health benefit exchange language from the statute as a model.
yeah, so the only thing I think that needs a little wordsmithing because of the,
okay.
Yeah,
okay, that's good. So in essence, it's sort of a, it's a checkbox to say we did it, and in measurement, you call that sort of a structural kind of measure, that you have a structure in place, and if there's precedent for it, hospitals, back when medication was being ordered through the computers rather than, in paper charts, it's called CPOE, and the hospital would check a box, yes, I have CPOE, and they would get credit in the Leapfrog program. So again, this would be a structural measure. It's in a chart.
I saw.
Yeah.
Is this designed just for the HSCRC? As you know, I mean, patient issues are going to be brought across, there's healthcare quality, there's MHCC and all that. Is this going to be broader to advise the state government in general, or just the HSCRC?
I think it's meant to be a dashboard that the HSCRC promotes and champions this measurement, but that it could have broad use to show how, on a dashboard, progressively, how are we doing on concepts we believe get at aspects of this consumer engagement.
But relate to the HSCRC or generally for
this
the
particular, if you're talking about, I think it's broader. It's consumer engagement, but
I just saying HSCRC is very, I mean, has some, certainly impact on consumers and patients, but it's really a broader group set of healthcare entities in the state that really have a much greater impact on consumers. So I mean, it's important that the HSCRC has some, has a, advisory group, continue having an advisory group. But I think what's could be more impactful is something broader, bringing in DHMH, healthcare quality, MHCC, and others.
Well, that was the task force recommendation that was somewhere earlier in our conversation, which we would expect that representatives from the Standing Advisory Committee could potentially serve on that. The chair or co-chair would liaison to that too. So I mean, I think that goes back to our central message, my central message, which I think is in here, which I think we agreed to, which is all of these things are happening out there and they've got to be integrated, and we've got to have a conversation where, everybody's at the table as we're talking about consumer engagement or the implementation of the process or whatever it is.
Right. So Steve raises a good point. Establishing that task force itself is another kind of structure that we could
put in here as a
and that gets at this broader issue. Yeah. Let's add more measures. Okay. So here this is again, the measurement part of me. Create connections among government, hospitals, healthcare providers, communities, etc. That's the objective. So we don't fully meet this objective by any means, but this measure does get at some aspects of it, which is measurement of the hospital meaningful use of patient and family advisory committees. And I would ask MHA or MHCC or both of them to work together to do this measurement. Myself, I think that responsibility, so we could, could encourage them to look at developing a new measure, and we would have
to use as a toolkit that Anne Arundel Medical Center has used so successfully.
Right. That was the Institute for Patient and Family Centered Care. Mm-hmm. So what, how do you define meaningful? Question. So
does that get at all of those components?
No.
The government, the healthcare providers, and the community providers piece?
No.
Okay. Didn't think so.
No.
So not that I have the answer.
Right.
I love the goal
and
the objective, but I don't know what measurement you can do.
Yeah. And like I said, if we take on too many measures, plus both of them aren't really specified, well, we won't be able to measure anything. So I think we need to take on some early ideas and try to flesh them out, and then think about other ways we could measure more comprehensively those issues. Or
I would agree, and Diane, you're the expert in the quality side for sure. Is there a way, though, because that objective and that measurement are not parallel, can we do a sub-objective that gets with that measurement, which is the hospital component? I don't want to lose the bigger goal, but I don't know how you do that, but it just seems like it's a major goal that has lots of players and a tool for one set of them.
So part of it is that in the introduction to the measure section, that we make the statement that just what Diane just said, we're not trying to take on the world at this moment. We know that that we need to, in order to get stuff done, we need to prioritize, right? And then perhaps, as Karen Ann suggests, do a subset under each one. So for instance, my Medicare piece could go as, next step, potential next steps for looking at measures, which is another role for the Standing Advisory Committee to take on.
Right. And then actually, I think the Standing Advisory Committee at the larger objective level, at the goal level, may get better at this objective too. So if we look at that, yeah. Okay, so the next one is to educate, engage, and activate people who use hospital services in policy planning, service delivery, and evaluation of services and agency levels to ensure ongoing consumer support. So this is a huge objective, and consumers' overall rating of a hospital doesn't really match that objective, but the one before it and the one before that also help get at this objective, I think, the measures, that is. Now, the good news is HCAHPS, there is an overall rating. I was in the hospital twice in the last 8 months, and I didn't even get my HCAHPS survey, so I'm a little mad. I wish I could have rated my hospital. I don't think I was selected, but obviously, maybe there was some purpose in the non-selection. So this survey's been around for a long time and is validated, and we could look at the movement of Maryland in general has an issue with low HCAHPS scores relative to the nation. So I think if we're really engaging people and they're coming away with a more satisfied sense that they know what's going on, they have good communication, they have an overall good positive impression. It's not just satisfaction. This measurement set, this survey has been higher HCAHPS scores. They've studied readmission rates, and there are lower readmission rates, for instance. So people who have their perceptions of care are relatively high, or what they got, the quality, the communication, et cetera, did have a better experience from a quantitative standpoint. And we're going to look at our HCAHPS scores at the hospital level in the next year or two relative to other measures of care like complications and readmissions. So that should be a really interesting exercise to see if we see anything significant in that.
Let me just point out we have 22 minutes.
Yeah, let's go.
There's no public in the room, so we can call for public comment, but it'll be very short. So
the short pause.
Time check.
So the next goal is engage, educate, and activate people in their own healthcare in order to promote efficient, effective use of the healthcare system. And so the CTM 3 questions that are part of the HCAHPS survey are going to have been collected since 2014. I wrote it there. So here's these questions, and they're really good questions. And they're collected as a matter of course. So I think we can look at movement on these questions and improvement in general, even at a statewide level, and that would really help us. And it's already collected. So we can go down to the next. And that was goal number 2. So objective 1 under goal 2 is to provide people who are users or potential users the information and resources needed to become healthcare aware consumers. So this one was a little tricky. So we could look at things like individuals with personal health records, like the patient portal Steve was talking about at CRISP. We'd have to develop these. We could look at the volume of materials, because some people will want electronic and others will want paper. For potential users, we could look at if there's movement and traffic on the website or websites we determine have the information about the waiver. The telehealth subscribers, any posts or comments on the waiver or any related articles. These are very, these get less and less defined as we go down the list. So we'd have to settle on what we thought. Maybe there's a Facebook page and we count how many friends. I don't know. But that, and I don't know if Hillary wants to talk about any of these, because you're the communications expert.
These are all, they're relatively standard measures for communications engagement. But as you say, it depends on which of the tactics end up going forward that you'd want to use. So part of the challenge with these is that they are more towards some of the specific tactics recommended than towards the overall objective. For example, with Facebook, if it's decided that there's not going to be a Facebook page, writing that in as one of the measures isn't going to be useful. So, so in a way, it makes more sense to define them at this level after what's actually going to go forward has been decided.
Right. Okay. I think it is a good idea, though, to look at the information you have available to you, and if you're disseminating information electronically through these different means, pick a couple and then watch the movement of it. I think it is a good idea. So the next one is to support consumer decision-making by providing clear, culturally and linguistic, appropriate, actionable information and opportunities for effective interactions with healthcare professionals. So there is the CCAT survey, which is the Communication Climate Assessment Toolkit. This also came up in the performance measurement work group that we convene as a potential tool that could be implemented to measure health literacy related to patient-centered communications, measure language service related to patient-centered communications, and to measure individual engagement related to patient-centered communications. So these surveys been developed and has these subdomains. They're listed here. But the trick is you have to have an infrastructure to administer it, and then you have to evaluate the results. And it's a new layer of, administrative budget line item that would have to sit somewhere. And unless MHA took it on and said, oh, we want to know these things about the hospital, question would be a matter of pragmatic one. The other question, though, which was for Linda Aldori, was, and I sent it to her maybe a couple weeks ago, so it's.
And is Linda still on the phone?
I am.
Hi, Linda.
Hi.
So I was hoping if you have been able to look at the materials, I caught you on vacation, so I apologize.
Yes, no, it's no problem. You caught me on vacation 1 week, and then this week I'm actually moving offices and staff. So right. The timing is pretty bad, and I apologize for that. Today's my last day, actually, as director of the Center for Health Literacy. So I'm transferring to communication and continuing my work in health literacy and health communication, but from the communication end. So I haven't been able to look at any of these documents with any detail. But as you know, originally we had talked about this being the best that's out there, because while there are many scales and indices used to measure health literacy, they're really not useful in this context.
And I think the discussion in our subgroup was that we might start with the hospital CEOs or the administration in order to sort of drive a culture change, and then move down the food chain and out. Am I correct on that?
I think we had mentioned that as a potential, but the thing about this survey is there's 4 parts to it. There's the CEO, there's the staff, and there's people who get services, and then there's a 4th one, and I think it's like a care team. So it would be anyone involved across the continuum, and then so you get, there's versions of this instrument for each one of those audiences. So,
and it may be that once we look more closely at each measure, each item, some of them might overlap with the HCAPS questions. We can look at that more closely.
Right, and I did send you the validation study as well. So there was a validation study done on the tool, which is the other reason why this could be a potential. But again, it's the pragmatic issue of administering it. And then the University of Denver, I forgot the name of the PI escapes me, but anyway, she does all the analysis for a fee. So then it becomes a pay issue. The HCAHPS questions do have consumer-specific ratings, communications with doctors, nurses, and the responsiveness to the of the hospital staff. And those measures have been in place since 12 again, with it in terms of us using it for payment. And then we could monitor increases in percentages of those particular questions. There's 3 questions in that area. So those are the measures. And then there were, where are the end-of-life measures? Oh, yeah, I don't either. None of us do. Okay,
I do.
So
It's up on the screen.
yeah, so thanks. So the last couple of objectives: educate consumers about the most appropriate setting to receive care. And so there, besides the CTM3, which is knowing your medications, knowing what to do when you get home, and I forgot the third question, there is a rating about how did you receive discharge information, and that speaks to the 84-year-old gentleman that Kim brought up. And we'd want to see an increase in the percentage of people. Did you understand it? Yeah. There are prevention quality indicators that looks at how we measure them already. So we could look at just decreases of them over time, because these are ambulatory sensitive conditions that should be able to be treated without having to go to the hospital. So these aren't readmissions. These are just any admissions that you go to the hospital for heart failure, hypertension, diabetes, and other conditions. So we could just look at those, and we already measure those. And then support consumers in the appropriate use of care planning and self-management tools. So we know that there's some measures in the care plans about using care plans in the partnerships. So we could look at trends in those data. We have the communication about medicines, HCAHPS questions, that's already in use. And we have percent of patients with chart documentation of preferences for life-sustaining treatment. Now there is something called a medical order of life-sustaining treatment requirement for, I think, readmissions and admissions to long-term care. Is that right, Novella? So we could encourage all hospitals, whether it's admission or readmission, and then it's been suggested for a couple of years now, Steve, I think, that if there would be a way for CRISP to capture that data. So that bottom line is that would need to be developed and live somewhere for us to be able to track it. And then the thing that's missing that I had intended to put in here, now that there's a proposal for end-of-life discussions for physicians to be paid, or providers to be paid for that, there would be a way to pull that out of the claims data set. And maybe but I don't know if you measure that relative to a hospice flag in the hospital, in the chart, or so if someone's on hospice and had a bill for that versus not had a bill for it, like what's a good number for that question? So, and I don't know how that would show, how you would, we'd have to figure out how that would show success.
Well,
just general use.
Yeah, just general use. I mean, if you're seeing an increase in the providers who are having those discussions based upon an increase in the claims, that's a measurement of success. I mean, you're going to set the goal. But
or it's a physician billing for another service when the patient wasn't on hospice. So let me be a devil's advocate about that.
Sure.
Okay.
Sure.
But so we'd have to figure out the details of that.
Yeah, absolutely. It's a resource. But Kim has been jumping up and down.
I'm just wondering if it would be appropriate to fold advanced directives in there with
Yeah.
possible.
Yeah, advanced directives with mulch.
All right.
Okay. And to make that more broad, and I think Gary has been the champion of that too. Yeah.
I think measuring the ownership. Measuring the ownership that people take of their care could use advanced directives. It could use medical power of attorney. It could also be each hospital maintains sites, and within the sites they monitor traffic. It could be what percentage of your patients or how many of your patients accessed your sites for patient education about their specific disease or whatever. You use it as a proxy for their specific disease, even if it wasn't tied that way. And what I'm driving at with all of those things is, if our objective is to get people to take responsibility for their own care, what objective measures are there that they've actually taken some action about owning their own care, whether it's to direct what I want done, who I want to make the decision about what I want done, or looking at, what is my disease and what are my options. So those, and I do believe, like you, that the discussion about end-of-life care, whether it occurs with a 30-year-old who's healthy or a 60-year-old who's got multiple diseases, is an indication that people are at least talking to you about owning your own care. It's one of the few objective measures that I could latch onto.
Yeah, and I mean, let me argue that the 35-year-old daughter of a 67-year-old woman who's having those conversations with her doctor is benefiting the 67-year-old because she's going to be making some of those decisions, or vice versa. So you get two for the price of one with the young. So thank you, Diane, for all of that. Let me just ask Hillary, do you want to say anything about where you are in any budget recommendations that are going to go in the report?
I'll say I'm not as far along as I'd like to be. Michelle Clark provided some estimates for, let me back up. About a week ago, we had some discussion in the subgroup about the challenges that we're seeing in terms of budgeting, because what it would cost to implement some of these things varies dramatically depending on where in the state you are. So we decided to look at a range and make the recommendations in those terms. So Michelle sourced some numbers for a rural community, and I've been trying to get various numbers for what it would be in a suburban community, as well as separately trying to get estimates from communications firms. Right now I have some initial things, but they don't make sense. So I'd rather wait until I can make them make sense before presenting, but can share things on email as they come together.
Steve, what do you think about the ranges? Would have to be necessarily broad, because we don't have time to go through all of them and refine them into specifics. Do you think it's useful at this point to even consider budget, or is it better to wait until we find the 5 things that people think, having read the report, are going to be pursued, and then start evaluating what the costs are and how they might be funded?
Yeah, and I think it's going to be difficult also. You may have some communities who are already well down the path of meeting those, and other communities that are not, even within a suburban area, different suburban areas. So I think I commend you, Hillary, for taking on the task, but maybe it might be a little bit easier if it's focused on just the top 5 or whatever it is that the group decides needs to be the main focus. I don't know.
Yeah, so I mean, I don't think I can't speak for Hillary. I'm not sure turning the ship to get to that point in the few weeks we have left is necessarily possible, and perhaps I don't know how much more work is involved, Hillary, in filling out where you are now and where you're going, and whether we look at that and then make a determination as to whether we put that in, or we also put that in the SAC bucket.
Or you put it as a recommendation of next steps.
Right.
Yeah.
Yeah.
Right.
Yeah.
I think there is a bit more work to do, but it's not a huge amount. Although I appreciate Gary's point too, in that might make a difference into how likely some of these recommendations are to get done, because when you put it all together, it's an awfully big number, and so that could be off-putting. So,
well, maybe. Excuse me, Hillary. Go ahead.
No, you go ahead. I was just trying to think out loud, which is never a good idea.
Well, dangerous when I do it, but maybe part of our core message is that again, to go back again to the integrated approach, and this is going to take funding from multiple agencies to make the whole thing work. But beyond, public funds, there also are foundations, to go to the foundations point, and other resources that we need to be looking at more broadly going forward for opportunity.
Mm-hmm.
Okay.
So you mean messaging that within what we present as a budget? Yes,
exactly. So that just to again raise the, so I mean we don't want to use the MHBE. We've all agreed to that. But in fact, before they hired an executive director, RWJ was giving out money for development of the outreach and enrollment communication strategy back in 2010, 2011. So, so those foundation dollars were already flowing into the states, right? And I think part of our message is to go back and say, this is a model that Maryland is creating. This is an opportunity for national foundations as well as state foundations to get involved in something innovative. That would be my sales pitch.
Yeah.
So, okay, so I think we're almost at time. I'm just not going to look at the clock. There's no public here, so let's talk about the next steps. So Hillary's going to take Tiffany's going to take what's been done so far at this meeting and before and integrate that into the documents that we have. And then we three will be looking at the draft and getting the next.
I'm going to do the recommendations.
And Diane's going to do the recommendations and the measures section. And so that our goal is that by Thursday, you will expect in your inbox with a high priority flag next draft of the report for your comments, which we will then need to turn around in short order. So we're going to ask for them in 36, 48 hours. So we can then present to you at the meeting on September 2nd here, 9:30 to noon again, the final report, because then we go to the commission on the 9th of September. So we are working on a really tight time frame, and we all have many other things to be doing, obviously, besides this. So,
Lenny, will this draft be start to finish so that all the separate documents are included in a single presentation format?
So the appendices, if that's what you're asking, should be there as well?
So we can see the flow of the, this is the package we're going to hand to whoever we're turning this assignment into.
Yes. So let me say, too, thinking about the webinar conversation that Diane and I had yesterday, and I know you all do this whenever you do a webinar or whatever, there's always that resource list at the end. So if there are some resources that you think should be as a part of this package, that we've shared a lot on Basecamp and so forth, but that would be useful to make sure we have those. Is that okay with you, Kim?
Just as a final comment, Barbara had wanted to just go back, well, right, tell you about the resource data concept, and if she's still on the line.
Barbara, would you like to?
else that needs to be said. I think it's been covered.
Okay. Yeah, no, thanks. So for those on the phone, any final comments? Any final comments from those in the room?
I'm just going to thank the people who have done the heavy lifting in this, because it's pretty impressive, the amount of work with Tiffany and Hillary and Diane and yourself. So Susan, whoever else, I don't want to leave anyone out, but I just want to thank the team.
Well, I mean, thank you, and I think to the group the subgroup that met seemingly every week too, and Hillary in particular, yeah, but you were part of that too, Karen Ann. So and for those who weren't part of that, I mean, the feedback, the story about the goldfish, that's perfect. Yeah. I mean, everybody's contributed. It's been just, I think, incredibly exciting, really. Okay.
Thank you.
So we will reconvene on September 2nd.